Good morning. My topic is on optic neuritis, the importance. I think some PGs are here. My usual question now, optic nerve is a nerve or not? Your answer should be it's not a nerve. It's only a white fiber tract connecting second order neurons, that's ganglion cells, to third order neuron is actually in iatrogeniculate body. It's going as white fibers, that's all. That's why, optic nerve, still we call it as optic nerve again, but normally it's not supposed to be a nerve. And moreover, it has got no neural lemma. That's why when get injured, you cannot regenerate. That's the major problem with optic nerve. Whereas but seventh nerve is there, you can have apparent regenerations. Third nerve is there, apparent regeneration. So many things can take place. Whereas optic nerve, when get damaged, it can never regenerate. Now we have got sometimes optic neuritis is there, isolated. Always remember, whenever you encounter a patient of optic neuritis, think the patient in future may develop multiple sclerosis. That's the most important aspect you are supposed to know. Then based on pathology or something, we can differentiate or tell it as periaxial, axial neuritis, transverse neuritis. That's the importance, why I'm telling now. Everyone knows that optic neuritis can have a visual field defect of central scotoma, centrocecal scotoma. That's what we know. But most important point, on which axons are involved, you are supposed to know. In optic neuritis, suppose the peripheral axons are involved, you can have peripheral contraction also. Once one of the macular fibers is involved, you get a central scotoma, that's all. That's why always central scotoma need not be always this problem of optic neuritis. It can be anything. That's why we should not get confused. So just by seeing the field, you cannot tell it's optic neuritis. Optic neuritis patient can have even peripheral that is contraction also, the fields depends upon that. Now when you see the fundus examinations, papillitis, of course you can see that, neuroretinitis, and then retrobulbar neuritis. Retrobulbar neuritis, everyone knows, you cannot see anything. The patient sees nothing, doctor also sees nothing. That is what being described as retrobulbar neuritis. Major etiology is what? Optic neuritis, if I asked as a postgraduate, always never forget tell about demyelinations. But the most important cause for optic neuritis is your multiple sclerosis, unless otherwise proved. Or even that it can go in for a primary optic atrophy sometimes. Primary optic atrophy, the most important cause is multiple sclerosis. Again you tell, don't change the answer. But you can tell there are so many causes, but the most important cause is multiple sclerosis. That's the most important, because retrobulbar neuritis can go in for primary optic atrophy. We have got any optic neuritis can go in for primary, unless the papillitis is there. Then only you can have post-papilledemic optic atrophy, post-papillitic optic atrophy. It can be infectious or non-infectious, so many things are there. Always remember, once you have got optic neuritis, depends upon the fibers involved. Sometimes the vision may be 6/6. Because when the macular fibers in the center, if they are not, like a vision of 6/6, that's why we call it as 6/6 neuritis. But still, I told you, peripheral neuritis may be there. That's the reason. So that's why 6/6 neuritis was one of the things we call it as. Most important major symptoms were visual loss, then pain in and around eyes, and color vision problems. Imagine now, the visual acuity may be reduced, but the color vision will be affected more, as in the case of optic neuritis. The comparative visual acuity, the color vision loss is more, whereas in macular lesions, correspondingly, vision may be affected, color vision may not be affected much. There's a difference, classical difference between optic neuritis and macular problems and all. Pain around the eyes and all, the reason is when you have a movements, elevation and erection. We have got the tendons of the middle rectus and the superior rectus. They have got connection to the dura mater of the optic nerve at the apex of the orbit. That's why when these muscles contract, elevate or adduct, a patient can experience pain. This is what is called as Whitnall hypothesis. Any PG is that they can note down Whitnall hypothesis, Whitnall. Then we can sometimes, multiple sclerosis patient is there. Uthoff sign is there. Uthoff sign is what? When you increase the body temperature of the patient, or when you exercise, the patient does some exercise, there will be something, chemical mediators or chemical substances are liberated, the demyelinating areas, they can get liberated. Further delay what the transmission of impulse. That's the reason the visual acuity can come down. One more thing is there, the demyelinating areas are there, the plaques are there. These plaques become edematous when you increase the body temperature. That's why they can compress the optic nerve further, the problem can increase. That's the reason for visual acuity reduction after exercise and all in a case of multiple sclerosis, that too in a case of optic neuritis. And never forget, usually optic neuritis is unilateral. But in children, sometimes they can be bilateral. So bilateral optic neuritis is very common, and usually in children, usually because of infections. Usually because of infections, classically, I think you might have heard about inferior petrosal sinus. That sinus area, the problem is there. The inflammation may be there. Inflammation may be there, which can affect your optic nerve and all these things. That's the reason for this. We can have RAPD is there. Understand now? Quantify. You can quantify the RAPD. How much of RAPD is there in the patient? How to quantify? See, just put a filter in front of the normal eye. In front of the normal eye, you put a filter. Decrease amount of light entering that eye. So that means the RAPD can be neutralized. That means you create in such a way the amount of reduction in the abnormal eye, optic neuritis eye, is equivalent to amount of light entering that normal eye. That means you are, by putting a filter, you are decreasing the amount of light. That means equalize. That means your relative apparent pupil defect can be reduced or can be neutralized. That's called quantifications. Fundus examination, you're supposed to know papillitis. You can have inflammatory edema is there. Optic now, you can have, most important point here is what? You can have cells in the vitreous. Whereas in a papilledema, all cells may not be in the vitreous. Visual fields, I told you now, we got central scotoma is there. Central scotoma, in the common question for them, when you have a central scotoma, how do you fix? How do you proceed with the field charting? They will ask you, because the patient cannot fix the center. How can you proceed further? Always there are so many ways. But in Humphrey perimeter, what we are using nowadays, just know that central scotoma is there. You cannot fix the central light. Then how to proceed? Your answer is, there is a large diamond is there, sir. Ask the patient to fix it's in the diamond. The fellow should not come out. So because he cannot fix, the same thing can be asked in germ screen and all. Suppose you're asked, germ screen, you can have some two ribbons, you can do this. They ask the patient to fix somewhere the ribbon may cross. You may not appreciate the crossing area, but yes, you should not come out of that area. Suppose the ribbon is not there, you can tell him, you can put a ring on the screen, ask him to be within the ring, he should not come out. Suppose the ring is also not there, the patient himself, he can use his thumb. The thumb, because proprioceptive impulse is there, he can fix. That's why ask the patient to put his own thumb, then you can find out the fields. That's the way you have to draw, or we have to chart out the fields in the case of optic neuritis patients, because he's having a central scotomas. Other demyelinating problems, of course, we have got Devix, all these things, Schilder's and all. Devix is what now? They got neuromyelitis optica. Here, what's the most important? Bilateral visual loss. That's the most important point. Bilateral visual loss, visual acuity reduction may be there in these patients. Para-infections means what? After viral infections, the patient can develop optic neuritis. Infections, classically, never forget cat scratch, syphilis, Lyme disease, cryptococcal. Now here, as a PG, we'll ask you, what is cat scratch is caused by? We'll ask you in exams. Just remember them with Bartonella henselae. At least know some of the names of the bacteria. Non-infectious sarcoidosis. Here, what you now, most important point in optic neuritis in sarcoidosis, lumpy and bumpy disc. That's the most important name you are supposed that's a name you are supposed to know. Lumpy and bumpy disc, the classical appearance of sarcoidosis. Neuroretinitis, here one important question will ask you. Never forget, demyelinating problems like multiple sclerosis will never develop neuroretinitis, because retina has got no myelin sheath. That's why multiple sclerosis, usually normal circumstances, will not affect your retina. Never forget this. This is the most important point, classical exam question. Differential, you can know what, compressive lesions, sinusitis, all these things supposed to do the investigations. But here when I tell you, if you ask the exam, the sinus, which is responsible for the most common sinus, which can produce optic neuritis, if you ask the exams, your answer is sphenoidal sinusitis. Other sinuses are there. Sphenoidal sinus is notorious to produce optic neuritis because it's a very thin bone is there in the optic canal area. This, of course, yes, these are some of the investigations. AIOS can mimic. They can also have a problem like this. Diagnosis, you have to rule of CT scan and MRI and all. Etiology means what? You have to do syphilis means you have to do some syphilis investigations for syphilis. Suppose I want to do tuberculosis, I have to do some investigation for tuberculosis. Like that, you can know, that's all. You know some etiology is there. You investigate for that particular etiology, that's all. Suppose you have got multiple sclerosis, Here is one classical thing called HLA-BT101. This HLA-BT101, that fellow, if he is having optic neuritis, you can 100% sure that fellow will, in future, he will develop multiple sclerosis. That's the most important thing you're supposed to know, because that's a predictor. Okay. Other studies in optic neuritis, the treatment part and all, we got optic neuritis treatment trial, CHAMPS studies that control high risk. These are all treatment part. CHAMPS means control high risk AVANX. AVANX means interferon beta 1A. Whereas ETOMS, early treatment of optic multiple sclerosis study. There are so many studies involved in this optic neuritis treatment. These are some of the things that's mainly for postgraduate students. Now never forget, because the patient is going to come to you first, because he's having visual loss. He's come to you as an ophthalmologist. Now your idea is what? You must know this patient in future may develop multiple sclerosis. That means you have to control multiples, because he can have more severe effects. That's the problem. Our idea is to find out the patient, early find out, early referral to neurologist is a must. Thank you.
Sir, thank you so much for your rapid fire on optic neuritis.